Hey everybody, I just wanted to say welcome to Sleep TV. Sorry we're having some technical difficulties here with Dr. Christensen's presentation. So I think we'll kick it off, Dr. Christensen, and let me just introduce you to the group here. You can talk us through the presentation. We'll try to get those slides up, and if we can't do it, then we'll send the presentation out for everyone to have. So um, Dr. Christensen's a graduate of Creighton University School of Dentistry, 1993, served in the Army for 2 years before going on to his orthodontic residency in 1997 in Louisville. I got to go there earlier this year and do a talk, so that was pretty cool. Ooh, we're getting some slides now on my end.
I got it to work.
Sweet.
I don't know how that happened.
I first met Bret in person about a year ago up in Northern Idaho in Coeur d'Alene for the Northern Idaho Dental Association meeting. He's a practicing orthodontist in Lewiston, Idaho, which is, would you call that Western Idaho, Bret?
Yeah.
He's got multiple children, a beautiful wife, Erica. They also run a hay business. So, you know, the cowboy in me loves that. But we're here tonight to talk about his changes in his philosophy of his approach to orthodontics, basically going away from the mainstream, what he was taught in school, because I think you probably saw something different. So why don't you give us your 2-cent bio there, and then we'll get started.
All right. Well, I was a little intimidated when they said there was 55 people out there. This is my first time I've ever done this. And so I hope that the stuff that I can share helps everybody that's out there. And hopefully it'll change the way you look at a patient, look at a kid, even an adult. But giving you a kind of a perspective on where I started as a traditional orthodontist, and in school they teach you to extract teeth and just make teeth straight and fix the bite. And for probably the first 5 years of my practice, I did that. And then as I treated little kids, and they had cross bites, when I expanded those little kids with an expander, I would have parents that would come back to me and say, wow, you changed my kid's life. And initially I thought, oh, whatever that is. And then as time went on, I found that if I expanded kids, I didn't have to pull teeth. And when I did that, I had more parents that would come and say, wow, my kid quit snoring. My kid was able to get off of ADD medicine or ADHD medicine. And so probably about 10 years ago, I finally said, you know what, I think I can do this without ever taking out teeth. And then researching more and more, not necessarily orthodontists, but dentists out there that were doing airway treatment with kids, I totally changed my philosophy with orthodontics and started being able to help little kids and focusing more on airways and breathing. And so when you start looking at kids in that realm, your focus goes away from teeth and it goes more on the health of the kid, but you use the teeth to get to your end goal of what you're looking for. And so now my practice, 20 years later in Lewiston, Idaho, with a population of 30,000 people, my practice is extremely busy, even through the downfalls and everything like that, because we focus on airways. And most of my patients come by patient referrals and medical referrals to help kids correct their breathing problems, their bedwetting problems, help them with their behavior problems. And it's all through looking at airways. And when you go into sleep medicine, I think the big push is mainly with adults that we look at and saying, hey, let's get these adults so they don't have sleep apnea. Well, when you look at little kids, some of them have sleep apnea, but a lot of them have what's called upper airway resistance syndrome, just small airways, and they struggle to sleep and breathe. And so when we look at, I'm going to see if I can, as I'm doing this, go and find, and you guys can see this, what I'm doing on here, right?
I can see your slide deck and like the PowerPoint off to the left. So you can either go to presenter mode, or you can just stay right there and just jump through the slides if you want.
Okay. Well, what I wanted to do is I wanted to see if I could show you some, oh, there we go. Here we go. I wanted to show you some pictures and some videos of one of my little patients. And I think what I'll do, and I know this is probably not the easiest way to do this, but what I'm going to do is I'm going to bring up a patient, and I'm going to just turn my computer so that everybody can see a little patient that's on here. And so there we go. Can you see that now?
I can see it.
Okay, so this right here, is that pretty focused on there? I can't see where it's at, but this right here is a little patient that we had that came in, and mom and dad were struggling with this little gal to get her to sleep and breathe. She snored, and she actually had sleep apnea where she stopped breathing. And when we look at her pictures, even when you look here, she's got the eyes that are just slumped, and she's tired. And now I'm going to have my computer freeze on me. That's nice. Oh, shoot. Just when you don't want things to go wrong, they do go wrong, don't they?
That seems to be the way it works out. So.
And there's nobody in my office to take up any space on this stuff. There we go. All right, so here's our little patient. There we go. Can you see those now?
Yeah, you're good.
All right, so this little gal, she comes in at 5 years old, and she's struggling to sleep and to breathe. And this is her bite. She's got a tongue thrust. She's got an anterior open bite, and kind of a little bit of a class 2 bite there. And when we look at her, she's got a V-shaped upper jaw. And this is at 5 years old again. And then when we look underneath here, she's got a little posterior tongue tie. And pretty sure I had these things. All right, let me get to this, and I'm going to show you guys a video of this little gal. Here we go. So this is Rowan sleeping before we started treating her. You can see the open mouth posture, just struggling to breathe. And that was her the whole time when she was just trying to breathe or trying to sleep. This is her after we did expansion. Mouth is closed and she's breathing through her nose. And her mom sent me these videos without even being asked to send them. And so you can see where she's at there. This is another one of her videos that mom sent beforehand, with her sleeping with her mouth wide open. And then here's her sleeping, and it's quiet. This is her about 3 months later, but she's breathing through her nose and she's not breathing through her mouth, and everything is quiet. So when we go from there, we go to the treatment on Rowan here. These are some of the pictures that we took just a couple of weeks after we started. And when we first started, you notice that she had no space between her front teeth. And right here is her 2 weeks into it. And then here's a couple weeks later. And this little guy up in here is actually what we call an Everly expander. And an Everly expander, the reason we call it an Everly expander is because my granddaughter at 3 years old had sleep apnea. And we designed an expander that we could fit on primary teeth and do expansion to grow the maxilla. And as you grow the maxilla, then you actually go in and open up the nasal airway for them to breathe. And so this is Rowan, you know, a few weeks down the road, and you can see how big the gap is there. But everything that we did on her was to change and help her be able to breathe. And so I'll turn this back around now and get back
Does your
to.
treatment plan include a frenectomy in that case, Brett?
We have not done the frenectomy on her yet. And the reason is at 5 years old, she wasn't quite ready for that. And so when you talk about frenectomies, and we'll get into that in the presentation here, but can you guys see the presentation now?
We can. You could probably hit the presentation key to make it just one slide, or you can leave it up the way you have it there if that's a challenge.
Okay.
That one right there.
Yeah, that one. There we go. All right.
Very good.
Okay, so what we'll do is I'm going to breeze through this because there's a lot that's in this. We'll kind of breeze through my family. Jeff talked about the family life that we have and everything. Definitely a horse guy and do triathlons and everything else. We'll skip through this, the heart part of here. But when we look at treating our patients, we use what's called epigenetics and biomimetics to treat patients. And so biomimetics is basically mimicking what nature was supposed to do but didn't do. And so in dentistry, we use biomimetics. You know, when somebody loses a tooth and they're missing a bunch, we use crowns and things like that to mimic what nature was supposed to do but didn't. And then in orthodontics, we do the same thing. When we look at the genetics of growth and development, there's different things that help the skeletal structure to grow. When we look at the skull cap, as the brain develops, it pushes against the soft spots, you know, the sutures in the skull, they expand and the head grows. When we look at the upper jaw, and we look down here on the bottom right of the screen, the upper jaw grows with forces that are put on it, and that force is actually the tongue. And so when you look at where the tongue is at and its formation, it begins early on in embryonic development. And at about 20 weeks in embryo, you know, halfway through gestation, the tongue actually starts to swallow. And the swallowing pattern is what helps the upper jaw to grow. And so if you have an anterior tongue tie or a posterior tongue tie, what happens is that tongue doesn't reach up and push into the palate like it's supposed to. And if it doesn't reach up and push into the palate doesn't give that stimulus like it's supposed to grow. And so you, even in embryo, you can have an underdeveloped upper jaw. And if you have an underdeveloped upper jaw, then what happens is then the maxilla doesn't grow, but the other side of the maxilla is the nasal passage. And so if you've got a small maxilla, you've also got a small nasal airway. And I see little babies that are born. We do quite a few baby frenectomies. And within even 4 or 5 days of these babies being born, they're mouth breathers. And if they're a mouth breather, like on this picture right here, you've got poor tongue posture, the tongue doesn't sit up in the palate, and therefore the palate doesn't get that epigenetic stimulus to grow and expand. And so if you can fix the maxilla or fix the tongue early in age, at birth, then you'll see these little kids that will grow like they're supposed to. But if you don't, and most orthodontists don't even look under the tongue. We were never trained to look under the tongue. It was only in sleep medicine that we even learn about that. Then once you find that most orthodontic patients have some form of a tongue tie. And so, let's see, there we go. And so when you talk about the tongue tie and its function, these are just some of the pictures of that. I'm going to go past a lot of these things. It's just the same thing as a frog that has a tail that doesn't go away after they've developed. A lot of the patients have a tongue tie. And it's interesting, the severity of the tongue tie that I see in kids equates to the severity of the malocclusion. The worse of a tongue tie, the less developed the maxilla, the worse off the bite, the more crowded those kids are. So I'm going to skip through a bunch of this stuff. This picture of the tongue tie is pretty darn common in my practice. I see a lot of these. And so we're going to go past a lot of this stuff. So if somebody, if you want to do a great benefit for helping kids with their airways, get that tongue to function right after birth and get that tongue so that it can reach up there and push in the palate. I've seen multiple patients. I had a family come in, it was probably 6 months ago, and they had 3 kids. 2 of them had severe malocclusions, crooked, crowded, class 2s. And both of them were like 80–90% tongue-tied. And then you've got the other child that was about 4 or 5 years old, had big spaces between the teeth and a perfect class 1 bite. And when we started talking about tongue ties, they said, oh yeah, this one right here, we had that one fixed when they were born. And so just by getting the tongue to function correctly early on in life made a big difference. And then when you look at how the tongue is supposed to function for breastfeeding, if the tongue can't lift up, you've got very inefficient breastfeeders. And if these kids can't breastfeed and push their tongue up there, you see a lot of those kids that are in the orthodontic office for crooked and crowded teeth, malocclusions. But then when you test them, you find out that there's big discrepancies in how their jaws grow. And so when you look at when to treat these kids, this is a graph that shows us how much of their facial growth and development happens with their ages. And so between birth and 2 years, you get 50% of their facial growth and development. That's a lot of facial growth and development that happens that if you don't have that tongue functioning correctly, then their maxilla doesn't grow and these kids end up being mouth breathers. By the time kids are 7 years old, they're 80% developed. And that's when the American Association of Orthodontists says, see a kid. I see kids traditionally now around 2 and 3 years old to get their maxilla to grow. And we do these little expanders on them. And so there's also there's been some studies that have been out that show that kids that have a high vaulted palate also have eustachian tubes and that are kind of kinked. And those are the kids that have more ear infections. We've had kids that chronic ear infections, you go in and expand their upper jaw, open up their airway, and that drains, and they don't seem to have those problems anymore. So again, with these kids that have these high arch palates, narrow nasal airways, underdeveloped jaws, and malocclusions. And what happens with these kids is if they can't breathe through their nasal passage, they drop their jaw and they breathe through their mouth. And when they do that, their bottom jaw is just hanging there, and it's not, it doesn't grow forward. It doesn't have that stimulus to grow forward when it's hanging there as an airway. And so that's where you see these kids that have these really underdeveloped jaws. And then when you see a kid that's got an underdeveloped jaw, their tongue sits closer to the back of their throat. And when it sits back there, then you can have obstructive sleep apnea in little kids. These are just the chronic mouth breathing phase that we normally see with these little kids that come in. If this video will work, I'll see if it works. This is one of my grandsons. His name is Beckham, and he's a little guy. Videotape Beckham breathing. Here we go. No, Beckham, let me do it. Hello. No, don't. Let me do it. So we have chronic, he's just chronic mouth breathing. He never would close his mouth. He's a brother. There he is. Videotape. All right. So that little guy right there, we've already expanded him twice. And he was developing a class 3 bite and underbite. And because of that, and what he was doing is shoving his lower jaw forward to keep his tongue out of the back of his throat. But he was also mouth breathing. And we've expanded him twice. And just by getting his upper jaw where it's supposed to be, open him up his nasal airway, he now has a nice class 1 bite. And he sleeps through the night. He doesn't have all the issues that he normally does. And so helping these kids to be able to breathe through their nasal passage with expansion is huge. I'm going to just pass up some of these guys. Again, when you have your kids that are mouth breathers, their tonsils and their adenoids get enlarged. One of the things that I found is when I initially started doing this, I would refer these kids when I saw the CT scan, I saw their tonsils and adenoids were really large. I would refer them to the ENT to go get their tonsils and adenoids out. Well, then I had some parents who were like, can we do this first to see if we need to take the tonsils and adenoids out? And it's interesting, as soon as you get these kids to be able to breathe through their nasal passage, their tonsils and adenoids start to shrink. And I've had more kids that we haven't had to refer them for a surgical procedure just by doing expansion to get their nasal passages open. And so there are constrictions that you can see on cephs and CT scans. The thing that I use every single day, and this is not an advertisement for the EchoVision, but I have 3 of these machines in my practice. I have one in each treatment coordinator room and one out in my clinic. And so every patient that comes through the door gets a baseline scan of their nasal airway and their oral airway. And then after we do expansion, we do another test to see where we are, get ourselves a, what do you call it? A report card of what we've accomplished. And so—
Hey, Brett, can I interrupt for a second?
Sure.
So what I've always wondered is on these kids, our markers are for the adult patient. Are you seeing that the nasal passage rhinometry is hitting those markers? Are they below it, above it? I know you're measuring year-over-year growth and development, but what is your 2 cents?
So when you look at the markers that you're using for an adult, remember that graph that we looked at that showed the development of the face? You know, like a kid that's got 50% of his facial growth and development by the time he's 2 years old.
Yeah.
Well, at 2 years old, 50% of a 6 millimeter airway is 3 millimeters. And, you know, by the time these kids are 4, 5, and 6 years old, you know, they should be up around, you know, 4 millimeters cross-sectional area. And their volume, you know, should be up around 4 or 5 cubic centimeters. So yeah, you don't, when you look at a kid, you don't expect them to have a 7 cubic centimeter nasal passage. But when they come in and they have a 2 cubic centimeter nasal passage, and then you take that along with your CT scan and look at that, then you can look at the parents and say, okay, this is why your kid is struggling to sleep and breathe. So I'm going to share. This is probably easier to see. This is my granddaughter Everly, the one that we named the expander after. And again, when you look at her and you look at her eyes, she just looks tired. She had multiple sleep problems that were going on, and so what we did is we put this little Everly expander on her. We fit it on 2 teeth on each side of the baby teeth. And then when you do this expansion, you can expand about 6 to 8 millimeters. And if you correlate that into the nasal passage, it totally opens up their nasal passage so they can breathe. And so this is Everly's tonsils when we started. And her adenoids were kind of big, not super bad. This is Everly just a few weeks later with her expansion that we did. And this right here, this is her mother's fingers, not mine. I would use gloves, but she's got a little posterior tongue tie in there. If you look down at the bottom teeth, her baby teeth, their bottom teeth are already crowded. And that's when she was 3. And so this is just 2 weeks of expansion, and you get that gap, and then she starts being able to breathe. So these are the things that we saw with her when her mother talked to us. She had night terrors. She was waking up like 7 times a night. She didn't have the sense of smell. And when she woke up, she was never happy. During the day, I remember one time we went out to lunch and she fell asleep in her food. And she did this quite often. And then her parents would record her, and when she, at nighttime, and she would stop breathing for 20 to 30 seconds at a time. And then she also was continuing to bedwet, but yet she was potty trained during the day, but at nighttime she would still wet the bed. And so just doing the expansion, she no longer had night terrors. She grew up with a dog, a big German Shepherd. And after expansion, she noticed that the dog smelled, and she kept complaining about how the dog smelled, and she had yet grown up with it, but never had smelled him before. She now sleeps through the night. She's 5 now, but she's a lot more fun to be around. And interesting, just in a month, her bedwetting stopped. And so, and when you put in these expanders, you want to leave those guys in for 6 months, because if you take them out too early, what'll happen is the maxilla will go back. You got to give the upper jaw enough time for that bone to grow across the top of the suture.
Do you also incorporate myofunctional therapy or a habit correction of any type?
If they've got, you know, a tongue thrust or things like that, whenever we do the tongue tie release, what we do is we have 2 myofunctional therapists in our area, and we send them to the myofunctional therapist first, and they work with them for 2 or 3 appointments just on starting to get tongue tone and tongue posture where it's supposed to be before we release the tongue tie. And then after the tongue tie is released, they've got a week of, you know, pretty rigorous stretches and things like that. And then they go along with the myofunctional therapist to get their tongue to function correctly from there on out. Luckily, I've got 2 really good ones that understand what needs to be done, and they, it's nice to be able to just refer those things out to somebody else.
We also got a question from Dr. Hart out in California. So hi, Toshi, thanks for joining us. But she's wondering, are you fitting the bands or are you just scanning and having a pre-fit or sized band off of the scan? How are you doing that?
We put separators in and take an alginate impression, and we actually make these same day. I have a great lab tech that's, we have a lab in our office, and she makes them, and it takes her about an hour from the time of impression until we can put them in. And so I've never done the scan. We do scan these little kids when we first start, but it's a lot easier to fit bands, especially when you're fitting 2 bands on the D's and the E's of the primary teeth, to have some space to fit those bands.
The other question that came in is there a window of opportunity here? What age is appropriate? When is it maybe too late? Is there a too late? I know you do some adult cases too, so.
You know what? I prefer to see these kids around 2 to 3. It's really hard on the 2-year-olds. They're not really anxious to let you get in there. By the time they're 3 years old, I have multiple, I've probably treated 100 3-year-olds in the last 2 years. They're pretty easy to work with, and you get amazing results. Like the little girl that I showed you before, she had a 300% increase in her nasal passage from when we started. And I can tell you the numbers of hers. When we first started her on the rhinometer, her cross-sectional area was 0.11 and 0.14 centimeters as far as the minimum cross-sectional area, and her volume was 1.74 cubic centimeters and 2.0 cubic centimeters. So that's really, really low, even for a 5-year-old. And our last reading that we got, let me slide this over here. Her minimum was right around 0.4 and 0.38. And then her volume was up at 4.5 cubic centimeters. So, you know, on an adult, we look at it and say we'd like to have that at 7 cubic centimeters. But when she started out, she had over 100% improvement in her volume and a 300% improvement in her cross-sectional area. You know, but if you don't do the rhinometer and test this stuff, you don't have any metric of, am I doing better? You know, all you have is a parent that says, my kid's sleeping better. And so I'm putting together a database of all of our patients for the last about 3 years. And we'll have about 1,000 patients in this study that we'll be able to show the before expansion and the after expansion on what happens with the nasal airways.
That's great. The other question that came in is, and I think I already know the answer to this, because do you ever use removable appliances, or are you solely a fixed expander type of guy?
Put it this way, on kids, I'm a fixed guy. No kid wears what you hand them. They'll take it out and they'll leave it out, they'll lose it. Now, as far as adults go, I do expansion on adults with a Schwartz appliance and mandibular advancing portion on there. And but kids, even into teenage years, if you give them something that they can take out, they're going to take it out and they're not going to wear it. And the other thing is how long do you want to take to get something accomplished? You know, with a Schwartz appliance or like a DNA appliance or something like that, that takes months and months and months to get a result. And with an expander that you turn, you know, once a day or once every 2 days, you can accomplish this in a month of doing expansion to get the results you want. The thing that I've seen with some dentists is they're like, okay, we got it, now we'll take it out, and they don't leave it in there long enough. And that's why I've left this screen up here. Leave that expander in there for at least 6 months and even longer after that. So, but then the question before is, when is a good time, or is there a window of opportunity? I get patients from, you know, birth up till 80 years old. And Is it easier on little ones? Absolutely. Can you still do it on 40-year-olds? I'm going to tell you, yes. I've got patients that we've grown their adults that we've grown their maxillas 8 millimeters. It's taken 2 years to do that. You can't do it fast. I mean, it's very, very slow growth, and you have to have a very compliant patient. But we've opened up, adults' nasal airways. I mean, I myself have grown my upper jaw 6 millimeters by using the Schwartz appliance and totally changed my nasal breathing. So any other questions that are out there, Jeff?
That is what I have right now, Brett. So
Okay.
it's about 6:45 now. So maybe 5-10 more minutes, and then we'll take a few more questions and wrap it up.
Okay. I mean, I can show you the appliances that we use. This is just one of the quick part of the study that we were doing and showing the difference in patients. We didn't put any names on here, just before and after rhinometer readings and the percentages of increases. Sometimes we have 45%, sometimes you get 2%. And it's interesting when you have a kid that's got a nasal passage that's good on one side and not good on the other side, you go in and do expansion. It's interesting, the side that you do the expansion on, or the side that was bad, usually gets better than the side that was good before. So it's almost like the body says, oh, this is where I need that expansion. This is where I need the growth. And so, that's one of the take homes we got from the preliminary data that we collected.
At what point do you introduce pharyngometry?
That's usually by the time they're 8 years old. So when you look at pharyngometry, especially these kids that are mandibular deficient, these kids have a pretty compromised oral airway. And so we only do just the maxillary expansion on kids. We don't usually do mandibular expansion and trying to get the mandible to grow until they get up around 7 years old, just because it's a lot in their mouth. We're just trying to get their nasal breathing. And what I found is you just do the maxilla expansion, a lot of times as soon as they can breathe through their nose and close their mouth, their mandible starts to normalize. The pharyngometer, we start doing that just as a metric so that we can show parents the difference in their oral airway when we do mandibular growth of their mandible forward and in width. And so anywhere from
that ties into a question that came in from Dr. Rigby in Colorado Springs. He was wondering, do you also do a mandibular appliance? Do you just solely rely on compensation growth and development for, fixing the garage is what I always tell people. The mandible is kind of the car that comes along for the ride.
I use what's called a fixed lingual expansion appliance, and I'm trying to find, they can still see these slides. I'll kind of talk about these and then I'll see if I can get to the lower expander.
Yeah, you're good. Slides are good. So
getting their mandible to grow forward, I have not seen that autocorrect in the 30 years that I've been doing orthodontics. You get the maxilla to grow. Now, let me correct that. Back when they're 2, 3, 4 years old, I've seen it autocorrect. By the time they're 7 or 8 years old and they're 80% of their facial growth and development is done, I don't see the mandible taking off and growing forward on its own. And so by the time they're 7, 8, 9 years old, by then we're helping their mandible to grow forward. And that's what I use these springs that are on the side. This is a little kid, Keegan, that had very deficient maxilla. You can see this before and after maxillary growth. And big class 2, you can see where his oral airway went from 6.3 millimeters to 12.6 millimeters in the time that we went in and grew his maxilla and mandible in width and mandible forward. Fun little thing. Anybody see the mesiodens on that upper panorex? It's a fun one. You don't even, right in the middle. So this right here, this is what I use for getting the mandible. And it's really, it's very, very slow expansion on the bottom. Where on the top, you can turn it once a day. On the bottom, I use this fixed lingual expansion appliance. We just call it a flea. We turn this in once every 3 days. So it takes us 3 months of expansion on, and we usually only use this on kids that are under 12 that are still in their primary dentition. By the time they're in their permanent dentition, I don't really use the lower expander. So I think that answers the one question, whether or not you use help with guided direction of growth. And so we do that with the maxilla and the mandible, and then we do that also with the springs.
Yeah, I think that's a good point. I've also had the privilege in the last year to listen to Professor Bromwich out of NYU, who talks about functional matrices. I can't pronounce my words tonight. But he's calling that, the chewing of hard foods at the appropriate ages. So basically, we've become a Gerber generation. We've pureed our foods. We've gone to bottle feeding. And what I was thinking earlier is like, how much of it is really, bottle versus breast, or how much of it is tongue function, swallow pattern, oral facial muscles. That was kind of what I was thinking earlier. But nasal patency and growth and development of the nasal passages, the functional matrix there is the positive flow of air pressure through those passages. So those are the two driving forces in this growth and development curve.
Right. Absolutely. That goes right along with everything that I talk about. So this is what I use on kids when they're over 12 years old and have their permanent teeth in. We do the expansion on the top, and then what we do is we put in fixed orthodontics. I put these little buttons in, and they wear some crossbite elastics. Most of the time you'll see on the mandible, all of these bottom teeth are totally dumped in towards the tongue, and they just need to be uprighted and stood up in the bone. And so we found that this works just as efficiently as that fixed expander that we use on the bottom for kids that are older. And I've been able to use even the fixed expander on some adults into their 20s. You do need to watch and make sure they're actually getting expansion and they get that sutural split. If they don't, then back things off, because you can push teeth out of bone if you're trying to go too fast and you're not watching, the maxilla. I'm a big fan of using the Schwartz appliance or the DNA appliance on adults, and I've seen amazing results with that. This is one of our patients that we did with him, and you can see the difference in his maxilla and mandible, but also you can see the difference of his oral airway, really tight back here and really wide open on that. So, other questions?
We are good right now. So we got a couple more minutes and then we'll wrap up with what's on deck. Sleep TV is coming back every week. So it'll be Tuesdays at, 8 p.m. Eastern time. So figure out your appropriate time zone. We'll post them on all the social media links as normal. And next week, I'll be the host. We'll be talking about sleep hygiene. I've got some special guests that'll be joining me. And then we just had a meeting this afternoon with some very interesting topics that are coming up. So share it with your colleagues, your friends. We've got some seminars coming up. And here comes a question from Dr. Hart. Are you doing, just went away, hang on. Are you doing home sleep tests for apnea on the kids and the adults?
No, we do the home sleep test for the adults, but I have not done those on the kids. I'm not comfortable doing that, so we refer those. We have a pediatric sleep medicine doc that's up in Coeur d'Alene. We refer those kids up to her to do the sleep studies on them. I'm really comfortable with the home sleep studies on adults, but I haven't branched off to doing the kids. If somebody
is that Dr. Yeager up there?
Yes.
Yeah, her husband, Tom, you've influenced him. He's another orthodontist in Idaho that has listened to your presentation, and he's about to get going in the same thing that you're doing down there. But What a privilege that would be, right? To have a physician that's a board certified sleep physician and an orthodontist.
Oh my gosh, that's a dream.
So I think they're gonna crush it out there. We do have with Sleep Group Solutions, we use a home sleep testing device that you can use on the age of 12 if they're 65 pounds and greater. Certainly the Knox T3, Knox 3 is probably the usual one, but really with pediatrics, an in-lab PSG is what sleep physicians are going to want to see. They want to witness what's going on. Those videos, I was a Healthy Start provider in my practice days. Those videos are golden because, I had children, and the last thing you want to do when they lay down to fall asleep is go in and possibly wake them up. But taking that video is so helpful. And I always introduce just like, I'm not some creepy guy that wants to see your kid sleeping, but I need to see what's happening. So,
yeah.
So it looks like we've put up a promotional flyer in the chat down there. And do you have any other slides that you wanted to get to that we didn't?
I was just going to show you this kid. It's case after case, and I have hundreds of these. This kid right here, Xavier, when he was referred to us, he was super crowded. And when you look at his nasal airways, and you look at the numbers down here, his volume of his right nasal passage was 1.3 cubic centimeters. And the left one was 7. Okay, so it was actually really good on one side and bad. After expansion, the one that was bad became better than the other one. So now that's the thing that I've noticed, and it's like, having these kids go from their minimum cross-sectional area of 0.05 millimeters to 5.2 is huge on these kids, just helping them being able to breathe. So I think it's something that's very simple. I think most dentists have access to a lab that could make these appliances for them if they're not comfortable making them in their own office. And it takes 4 little bands to fit on those guys, take an impression and send it. I'm sure that there's people out there that do it with the scans. We're just so efficient at taking an impression and getting it down, pouring it up that, and I don't use any outside labs for any of that stuff. So, but if anybody wants help on that, I'd be happy to help them. It makes such a huge difference in all these kids. So
that'd be great. If you go down and stop your screen share, I think we can go back to full view of ourselves. But the last question that came in is from Ken, and he's wondering, and this comes up all the time, especially in pediatrics, are you using oximetry to study these kids versus HST?
I'm using the oximetry as a metric to see where I'm at. There's such a range of sleep disorders in kids. I don't think that, and the treatment for these kids is going to be very similar, whether or not they have sleep apnea or they have upper airway resistance syndrome. These kids can't breathe, and just getting them to breathe and having a metric to look at them and say, okay, here's where they started. Do a month of expansion. And if you don't see a big change, then you need to say, okay, wait, why didn't we see the change that we were looking at? Because everybody has those patients. But if they see a big change and the parents, see the big change in them and they can breathe and you can see it graphically, then I don't see the point in putting these kids through a sleep study. If you have kids that you do and you don't get a result, then yeah, that's when you refer them off. But most parents are more than happy to try something for a month or 2 before sending them off to do, tonsils, adenoids, surgical procedures, going through a home or a sleep study that's, $3,000 on their kid, when they can. And honestly, what we charge for these expanders is $1,000, and so you have to look and say, okay, how much does it cost to go through all this other stuff when the treatment is going to be very similar? The reason for sleep apnea in kids is compromised airways. How do you help them? You make those airways bigger. You know, I always tell people, if you start out with an airway like this, and you have an allergy attack, it could go to here. If you start out like this and you have an allergy attack, it can go to here and it can be blocked off. So we have a lot of kids that come in, you know, it's like, oh, during this time of the year, my kid snores and everything like that. One of my staff members, her daughter's been on allergy medicine her whole life. We expanded her. She hasn't taken any allergy medicine ever since we expanded her, because we opened her airways. She still has allergies, but she's got a bigger airway to breathe. And so I think we need to get away from thinking that everything's sleep apnea and look and say, how do we help these kids have a better airway so they can breathe all the time, versus, you know, getting stuck on that one, you know, the big part of it of sleep apnea.
Yeah, I think it's super important. And certainly my background was, the first dentist I worked with in Colorado was a pediatric dentist, and we had, he taught me functional orthodontics. So back then in the mid 90s, we were, you know, uncrowding teeth. In reality, we were improving airways, and these kids all tend to be on the slower end of the growth and development curve. But once they get to breathe, they grow faster. So Jose is going to put up that slide of upcoming seminars for Sleep Group Solutions. As a compensation for bearing with our technical difficulties tonight, there is a 50% off promo code that anyone's welcome to join. I will be coming up in San Antonio, Texas, and then Palm Springs and Denver. I'll have those 3 locations that I personally will be speaking. So if anybody that's on here is particularly interested in pediatrics and orthotropics, I'd love to sit down and chat with you. If it's at the seminar, awesome. Otherwise, just send me a text message. I put it up in the chat window earlier with my mobile number. You can send me a text, send me an email, and I'll be glad to schedule a time to meet with you. So with that being said, it's game 1 of World Series tonight. So hopefully some people are not Atlanta Braves or Houston Astro fans. And I thank you, Dr. Christensen, for your time. Our friendship has been a great asset in my time with Sleep Group Solutions. So we appreciate your efforts today in giving us an excellent presentation.
Well, sorry for the delay in the front, but hopefully everybody can take this and go do something well for those little kids. That's my hope and goal. Thanks.
That is where it starts. If we're going to make a difference, it goes beyond appliance therapy. That's my message. Tried and true. We have to treat all of these patients that pass through our general dental practices, but we really need to start looking hard at the kids if we don't want to just create another generation that has exactly the same problem, if not worse.
Right.
All right. Good night, everybody. Thanks for joining us. See you next week.
Good night, everybody. Good night, Dr. Christensen.
Thank you.
Good night, Jeff.
Night, Jose.